So NCCN, of course, has panels that are considering the best available evidence. For the purposes of today's discussion, let's focus on mantle cell and CLL / small lymphocytic lymphoma. So for mantle cell, mantle cell's been a really tough disease to treat for a very, very long time. If you look back on the history of mantle cell, of course, mantle cell was thought to be just another subtype of chronic lymphocytic leukemia, except those patients did much, much poorer than CLL patients. They relapsed. They died of their lymphoma fairly quickly. And then we started to understand a little bit about the molecular biology of it and a little bit about what makes mantle cell different. And so mantle cell was distinct in treatment recommendations. Even within mantle cell, there's a couple of subtypes. But when people think about mantle cell, they usually think about the aggressive subtype of mantle cell. And the aggressive subtype of mantle cell is treated much like, interestingly, aggressive lymphomas, like diffuse large B-cell. So there are kind of conventional aggressive regimens, like R-CHOP is frequently used, especially in the community, to treat these patients. And then there are other regimens like hyper-CVAD, which was from, I believe, MD Anderson a million years ago. The idea being to get patients into a good remission and then consider them for transplant in first remission or at first relapse. Now, given the age at onset of mantle cell lymphoma, that's not such a wonderful option for most patients. And interestingly, it's a heterogeneous disease, and there's some patients who actually seem to do pretty well. Until recently, treatment of relapsed and refractory mantle cell was really not particularly good. But that changed really, I think, when it became clear that this new class of drugs, the BTK inhibitors, were active in this disease. So ibrutinib was the first one on the scene. Acalabrutinib and acalabrutinib and zanubrutinib came later. These drugs are highly effective in treating relapsed and refractory mantle cell, often for a very durable period of time, often with quite acceptable toxicity. So the NCCN Guidelines recommends the efficacy of these agents and, in fact, offers them as a treatment of choice, if you will. Chemotherapy can be repeated in these patients, particularly those who have a very, very good first remission duration. But in patients who have the truly aggressive type, we're seeing the BTK inhibitors becoming the predominant therapy. Interestingly, we're going to see CAR-T make its way into this space. There's no reason why CAR-T shouldn't work in these patients, and so we will undoubtedly see that emerge over the next period of time. But this is not a particularly common subtype of non-Hodgkin's lymphoma. It's only about 4% or so of all non-Hodgkin's lymphomas. So getting big studies done in this patient, it's kind of tough. So CLL and small lymphocytic lymphoma are a little bit further along than mantle cell. For one thing, it's a lot more common. For two, it's another disease where we really were kind of stuck in a rut for a very, very long time. Conventional chemotherapy was used for a very, very long time. Mind you that not all patients with CLL, SLL actually need treatment. Many of them can be observed for a long period of time. They're very indolent disease. But in patients who need to be treated, particularly those who are symptomatic, standard chemotherapy was the treatment of choice. Bendamustine rituximab or FCR were chemotherapy regimens. Problem is, particularly FCR, is tough therapy. Old people do not do well with FCR. Now, several years ago, the BTK inhibitors came out. Ibrutinib has been around for several years now, is recommended as the treatment of first choice based on very good phase 3 randomized clinical trial data. Again, acalabrutinib and zanubrutinib came out more recently. Again, we're starting to see data with those agents in CLL and SLL. Initially now in the relapsed and refractory setting, but they'll make their way up the chain. That's just what's going to happen. We have other classes of drugs. Interestingly, we've got the PI3 kinase drugs, idelalisib and duvelisib, totally different mechanism of action, very effective therapies. And then the drug that may wind up actually being the best of all of them is venetoclax, which is a BCL2 agent. And all of those got a lot of press at the recent ASH meeting.